Dear students, today I would like to deal with acoustic neuroma. As the word implies, it is a tumor from the nerve cells and a tumor related to hearing. But the word acoustic neuroma is a misnomer. It is neither acoustic, it is neither from the acoustic nerve, nor it is a neuroma. It is from the vestibular part of the eighth nerve, not from the cochlear part. And it is not neuroma, it is neurinoma because it arises from the Schwann cells. That is why the better name is vestibular schwannoma. But still, by tradition, we continue it as acoustic neuroma. And it forms about 80% of all the cerebellopontine angle tumors and about 7 to 10% of all brain tumors. As I already mentioned, it is from the Schwann cells and it is benign, encapsulated and very slow growing, almost like 1 millimeter per year, 0.1 millimeter per year. And on histopathology, you would find elongated spindle cells with rod-shaped nuclei lying in palisades, in rows. See, this is a very classical picture of the schwannoma. And once it arises, it slowly expands, increases in size, and resulting in widening of the external auditory canal. As we all know, the statoacoustic nerve, once it emerges from the cerebellopontine angle, it enters the internal auditory canal. This is the picture of the internal auditory canal. In the internal auditory canal, the arrangement is along with the facial nerve. Along with the facial nerve. See, the facial nerve, seventh nerve is here, and below it is the cochlear part of the eighth nerve, and this is the superior vestibular nerve or superior vestibular part of the eighth nerve, and this is the inferior vestibular part of the eighth nerve. Now, how do we remember? This is anterior, this is posterior. Anterior, there is seventh nerve. 7 up, you can remember 7 up, whereas down it is cochlear nerve, Coca-Cola. Coca-Cola here, 7 up is above. This is anterior and superior vestibular nerve and inferior vestibular nerve. As we know, there is a little small bony projection here between the facial nerve and the superior vestibular nerve. This is called Bill's bar. This is a very important landmark during dissection to identify the cleavage between the facial nerve and the superior vestibular nerve. In the same way, there is another bony landmark that is called transverse crest between the superior and inferior vestibular nerves. And the superior vestibular nerve it gets fibers from the superior semicircular canal and also utricle, whereas the inferior vestibular nerve gets fibers from the lateral semicircular canal and posterior semicircular canal and saccule. And the small foramina is called singular nerve. This is from the posterior semicircular canal. Now, if the tumor increases in size, especially superiorly, it encroaches on the fifth nerve. Fifth nerve is at the apex of the petrous pyramid, whereas the internal acoustic meatus, it is on the posterior surface of the petrous pyramid, just a few millimeters from the apex. So once the tumor enlarges in size, it will impinge on the fifth nerve and produce fifth nerve symptoms, trigeminal symptoms. And the same way, if the tumor increases in size and extends inferiorly, then it will involve the ninth nerve, that is the glossopharyngeal nerve, vagus nerve, and 11th nerve, that is accessory nerve. Now, if the tumor is very large and it occupies the entire cerebellopontine angle and it applies pressure on the brainstem, as a result, it may produce symptoms and signs of raised intracranial tension. What are the symptoms of raised intracranial tension? Projectile vomitings, that is, vomitings that are not preceded by nausea, severe headache, and papilledema in the eyes. These are the symptoms and signs of raised intracranial tension. You can see in this diagram, this is the earliest tumor intracanalicula. It has increased in size. It has gone beyond the internal artery canal toward the cerebellopontine angle. And it is almost approaching the fifth nerve. Now here you can see it has encroached on the fifth nerve. And the lower cranial nerves, 9th, 10th, 11th nerves, they are still spared. Now in this picture, the tumor has very grossly engorged. It has involved the fifth nerve and also involved the lower cranial nerves, that is 9th, 10th, and 11th cranial nerves. So the classification is, earliest tumor is intracanalicular tumors, whereas a tumor up to 1.5 centimeter, it is a small tumor, and tumor in between 1.5 to 4 centimeters, it is medium-sized tumors, whereas a tumor beyond 4 centimeters, it is a large tumor. Previously, we are never able to diagnose acoustic neuromata unless they are the size of a cricket ball. Now things are different. Thanks for the advances in radiology. Now we are able to diagnose even the smallest size of the tumors in the intracanalicular stage itself. Now, how does it clinically manifest? Generally, it happens between 40 to 60 years of age, equal incidence in both sexes, and the classical symptom is unilateral sensorineural hearing loss and unilateral tinnitus. If a patient complains of unilateral tinnitus, or if we diagnose unilateral sensorineural hearing loss, it should not be just brushed aside as a simple case. Efforts should be made to rule out the intracranial pathology, especially the acoustic neuroma. And very rarely it may present as a sudden unilateral sensory neural hearing loss when there is a hemorrhage into the tumor mass. Till then it doesn't produce many symptoms, but once there is a hemorrhage, it will manifest as total sensory neural hearing loss. Then the patient may approach you. So it is mandatory to evaluate, investigate very thoroughly every case of unilateral sensory neural hearing loss, unilateral tinnitus. And apart from that, the classical picture in case of the acoustic neuroma is poor speech discrimination. That means they cannot understand speech. So understanding of speech is a phenomenon related to higher centers. So the speech cannot be identified easily. And in these cases, even though the tumor is straight from the vestibular part of the eighth nerve, there is no vertigo. But in course of time, as the tumor increases in size, there will be unsteadiness. Of course, if the tumor compresses on the cerebellum, there will be cerebellar ataxia. The patient tries to fall towards the side of the lesion. And if the fifth nerve is involved, then there will be what is known as corneal anesthesia. If you apply, if you touch the cornea by means of a sterile cotton wick, generally we blink. But if there is corneal anesthesia, patient will not be blinking. He will be tolerating the touch on the cornea by the cotton wick. Apart from that, there may be mesenteric weakness. You ask the patient to clench the teeth and there will be unilateral weakness of the mesenteric muscle because of the involvement of fifth nerve. There will be hemi-anesthesia in the face also. And not only that, if the seventh nerve is involved, frank involvement of the seventh nerve is very late. There may be lag of thalamus, that is delayed blinking, and gradually there will be total facial paralysis. It's very late symptom. Earliest symptom is what is known as Hitchelberger sign. Hitchelberger, name of a neurosurgeon who has described this sign. He has demonstrated few branches from the seventh nerve which supply the posterior aspect and medial aspect and floor of the external canal. So there will be anesthesia of the floor of the external canal, also in the Simba concha, very classically in case of acoustic neuroma. And not only that, if the tumor increases inferiorly, as mentioned earlier, it will involve the ninth nerve, that is glossopharyngeal nerve, and also the 10th nerve, resulting in palatal and pharyngeal paralysis and also laryngeal paralysis, vocal cord paralysis. If the tumor is very, very gross, then the 11th nerve, that is the accessory nerve, 12th nerve, that is the hypoglossal nerve, producing paralysis of the muscles of the tongue, and also 3rd, 4th, 6th nerve, that is the muscles of the extraocular muscles of the eye. So all these nerves may be involved in the late stage, advanced stage. And if the tumor is very large and if it applies pressure on the brainstem, there will be pressure on the motor fibers and there will be motor weakness, weakness of the hand and leg, and also there may be disturbance of the sensory fibers. That is, there will be hemi-anesthesia and there will be loss of sensation. And cerebellar science, as we all know, if the pressure is on cerebellum, there will be ataxia, and staccato speech, monotonous speech, and dysdiode apokinesis, that is inability to do alternate movements, and finger nose ill coordination, and there will be tremor, uh, intention tremor, coarse tremor, in comparison to the extrapyramidal syndrome, where you get in Parkinsonism, you'll get fine tremor, that is tremor at rest, and there will be signs of increased intracranial tension. And how do we diagnose? Yes, we have suspected. Now, how do we proceed? Fundamental investigation is pure tone audiometry to confirm the sensory neural hearing loss. Now, very classically, the sensory neural hearing loss is a high tone hearing loss, high tone loss. In case of early Meniere's disease, that is also a sensory neural hearing loss, but it is low tone hearing loss. Here it is high tone sensory neural hearing loss, and poor speech discrimination, and there will not be any recruitment. Recruitment, I think you all know, recruitment is a phenomenon by means of which the inner hair cells take over the function of the outer hair cells, and the lower intensities are not had, higher intensities are had more than normal, louder than normal. That is called phenomenon of recruitment, which is a very classical feature of end organ lesion, that is involvement of the organ of party, like in venous disease or presbyosis or autotoxicity. Such phenomenon will not be there. How do we demonstrate recruitment? By means of short increment sensitivity index test, SISI, in audiogram. What does it mean? What does short increment sensitivity index test mean? Suppose an individual is able to hear, say, 400 frequency at about 10 decibels. Suppose an individual is able to hear 400 frequency at, say, 10 decibel loss. Now, you present the same sound with 400 frequency at not 10 decibels by 1 decibel increment, that is 11 decibels. Now, these two sounds, that is 400 frequency at 10 decibels, 400 frequency at 11 decibels. These two sounds, you make the patient hear alternatively and ask the patient whether he is able to differentiate between them. Normal human cochlea cannot differentiate 1 decibel increments. If the cochlea is diseased, then the individual can be able to differentiate. That is because of the phenomenon of recruitment. So we do this test for, say, about half a dozen frequencies and calculate an average, and we calculate the CC score, that is short increment sensitivity index test score. If the score is high, say about 80 to 90% or even higher, then it must be a case of end organ lesion like venous disease. If the CC score is very low, then it is of no significance. If the score is via media, say about 20 to 40% or 50%, then it has to be evaluated further. We might be dealing with a case of retrocochlear lesion like acoustic neuroma. Next test is tone decay. What is tone decay? If you apply once again a particular sound at a particular frequency, then it is had for a particular period. But in case of individuals suffering from a retrocochlear lesion like acoustic neuroma, there will be what is known as tone decay. That is, the sound is not heard for the period that is normal for the particular frequency. So it will die down early. This is called tone decay. This tone decay will be classically seen. It can be demonstrated by means of the audiogram. And if you conduct the cold color test for individuals, you will classically see either incomplete canal paresis or complete canal paresis. You know very well, if you irrigate the ear with cold water, the eyes will deviate toward the opposite side, producing nystagmus. If you irrigate the ear by warm water, then the eyes will be deviated toward the same side. The tip is cows, COWS. Cold water opposite side, warm water same side. So in case of the acoustic neuroma, either you irrigate with cold water or warm water, there will be incomplete paralysis or complete canal paresis. There will not be any reaction. And thorough neurological examination has to be done for motor signs, sensory signs, cerebellar signs, fundoscopy, and all. So once you diagnose the patient clinically, then you have to subject the individual for radiological investigation. Radiological investigation is by X-ray skull, either transorbital view or stanverse view. Stanverse view is nothing but oblique view, or down view of the skull, all to demonstrate the internal auditory canal. You have to compare the internal auditory canal from this normal side to the diseased side. So the diseased side, internal auditory canal will be engorged more than normal. Now nobody takes an ordinary skygram X-ray. People dependent on CT scan. CT scan is very, very useful. If you subject the individual for a CT scan study, then you can see the classical lesion. So if the lesion is very, very small, intracanaliclar lesion, they used to inject intrathecal air through the lumbar puncture. So because you have injected the air, you will be find the lesion in the external canal very classically. Now, this MRI with gadolinium contrast has totally revolutionized the diagnosis of acoustic neuroma. If you subject the individual with MRI scan with contrast, you can see the tumor very clearly. See, this is the classical picture. This is the tumor mass. This is the coronal view, and this is the sagittal cadence. Now, if you want to differentiate between acoustic neuroma and other CP angle lesions like meningioma, you have to do a vertebral angiography so that we can differentiate the tumor from other lesions. And not only that, there is one advanced audiological investigation called BARA. What is BARA? Brainstem evoked response audiometry. Brainstem evoked response audiometry. What is brainstem evoked response audiometry? It is an objective test to know the electrical activity in the auditory pathway in response to the auditory stimuli. It produces 6 waves, 1 to 6, each wave representing one anatomical site. The easiest way to remember is E coli. E for eighth nerve, E for eighth nerve. The wave 1 is for the distal part of the eighth nerve, whereas wave 2 is for the proximal part of the eighth nerve. Then C is for the third nerve, that is for the cochlear nucleus. O, next O is for the olivary nucleus. L is for the lateral lemniscus, and I is for the inferior colliculus. So E coli, this is the tip one can remember. So out of all these waves, the third wave, the first wave, the third wave, and the fifth wave, they are very constantly seen. And you have to compare between the 2 years, a delay of more than 0.2 milliseconds of wave 5 between the 2 years is significant. That means the delayed side is the case of acoustic neuroma. Sometimes the entire fifth wave, wave 5 will be absent. Now, what are the differential diagnoses of acoustic neuroma? First and foremost is Meniere's disease. Both the things may mimic like each other. Very classically, patient may have tinnitus, and sometimes patient may have vertigo or unsteadiness and sensory neural hearing loss. So it is mandatory to differentiate between these two things. One can be mistaken for other. So we can either differentiate between either by BERA or by an MR, magnetic resonance imaging study. And other CPA lesions, CP angle lesions like meningioma picture will be very classical. It is more radio opaque, and you can do a vertebral angiogram and also confirm the same. It is more vascular. Or there may be primary cholecystoma. Primary cholecystoma is congenital cholecystoma, which occasionally is seen in the cerebellopontine angle also. Same cholecystoma as we see in the ear. And there may be an arachnoid cyst. Arachnoid cyst also can be mistaken. It will be radiolucent. And there will be schwannomas of the other cranial nerves, like schwannoma of the fifth nerve or ninth or 10th nerve. And there may be aneurysm, which also look like an acoustic neuroma, or it may be a case of glomus tumor. Other features will be there. Other features like the pulsatile tinnitus inside the eye and brown sign may be there, and you'll find a lesion in the jugular bulb. And very rarely, metastasis from elsewhere in the body also can produce a similar picture like acoustic neuroma. Once diagnosis is made, how do we treat? Treatment is first and foremost. If the lesion is very, very small, then we can do what is known as wait and scan. Wait and watch or wait and scan. Because it's a very, very slow growing tumor, 0.1 millimeter per year. So you can go on watching it for a period of time. But if the tumor is considerably bigger, then there is no point in waiting. You have to subject the individual for surgery. So what surgery you do? Surgery is excision of the tumor. If the hearing is intact and if the tumor is intracanalicular, then you have to take up what is known as middle foci approach for excision of the tumor. But if there is no hearing, or if there is no serviceable hearing, there may be very little hearing that is left. Then you can take up what is known as translabyrinthine approach. If the tumor is very large, then you can do what is known as suboccipital retrosigmoid approach, which is a very popular approach by the neurosurgery fraternity. The first two approaches, they are popular with the otolaryngologists. Or if the tumor is very large, you can do a combined approach, combined suboccipital approach and translabyrinthine approach. If patient doesn't want surgery or patient is not fit for surgery, and due to some reason or other, if you want to postpone surgery, you can subject the individual for radiotherapy. By radiotherapy, we don't mean ordinary cobalt radiotherapy. It is of no use at all. It is the gamma knife surgery. So by means of gamma knife irradiation, you can control the tumor. It will arrest the spread of the tumor. Now, coming to the middle fossa approach of the acoustic neuroma surgery, this is the ear on the right side. We take a U-shaped incision just in the retroauricular region and elevate the flap. Now this is the temporalis muscle. You can take a piece of temporalis fascia and then elevate the muscle also. Identify the bone. Once you identify the bone, then you can take, excise a piece of 4 centimeter into 4 centimeter piece of bone. And this is the middle fossa jora. Once you identify the middle fossa jora, then you elevate the jora by means of the special brain retractor. This is the floor of the middle fossa, and this is the special retractor designed by the House group, House Urban Retractor. William House is supposed to be the father of neurootology from House Ear Institute in California. Now, you identify the doom of the superior semicircular canal, that is the arcuate eminence. Just medial to it, just posterior to it, you drill the bone. Then you will be identifying the greater superficial petrocellular and the geniculate ganglion, and go medially identify the facial nerve and also the superior vestibular branch of the facial nerve. This is anterior, this is posterior. You can see the classical tumor here. And Professor Hugo Fish has demonstrated that the internal auditory canal is at about 60 degrees angulation to the arcuate eminence. And if you identify the tumor, especially with respect to the superior vestibular nerve, then we can excise it after cutting the superior or inferior or both vestibular nerves. Very rarely you may find ICA, anterior inferior cerebellar artery, which is in a variable relation to the intra-aortic canal. Then you should be very, very carefully, you have to retract it. And next is the translabyrinthine approach. What is translabyrinthine approach? As the word implies, you have to do a labyrinthectomy. You give a classical post-auricular mastoid incision, William White's incision, a little above and below, and you do a mastodectomy, a simple mastodectomy, otherwise a complete mastodectomy, and you skeletonize the facial nerve anteriorly. Identify the 3 semicircular canals. This is the lateral semicircular canal, this is superior semicircular canal, this is the posterior semicircular canal. And if the sigmoid sinus is placed very anteriorly, then the operating area is very, very crowded. So you have to drill the sigmoid sinus and make a bony island, which is known as Bill's island, so that you can compress the sinus for access. Now, once you identify the semicircular canals, then you can drill the bone. This is called the solid angle. That is the bone that covers the labyrinth. It's the toughest bone in the body. and a labyrinthectomy is performed. Once you perform a labyrinthectomy, then you can see the vestibule, and you can find the subarachnoid arcade artery inside, which is a vestigial artery. And if you drill further, you can classically see the eighth nerve complex. That is, you can see the small bony projection called Bill's bar, which separates the uh, facial nerve anteriorly and superior vestibular nerve posteriorly. And you can also identify the transverse crest, which lies between superior and inferior vestibular nerves. And now you identify the posterior fossa jura, and you can give a jural incision. This is called apron flap incision, and go to the CP angle lesion region. Very classically, you can see the tumor. I can incise the sheath of the tumor and remove as much tumor as possible and approximate the sheath laterally, sheath subsequently. Now the capsule collapses very classically. We have already cut the vestibular nerves, and you can close the wound. So this is translabyrinthine approach. We can conserve the facial nerve. We can remove as much tumor as possible. Even larger tumors also can be addressed. And generally, this is done along with the neurosurgeons. The main part up to the tumor level, it is done by the otolaryngologist. Then the neurosurgeon will take over and remove the tumor proper. Thank you.